Good afternoon, and thank you for inviting me to this session. HIV genotypic resistance testing relies either on Sanger sequencing or next generation sequencing. Sanger sequencing determines the consensus sequence, but only variants representing more than 20% can be detected, and there is no quantification. NGS allows the determination of the swarm of variants in the viral population, and minority variants representing less than 20% can be detected, and there is a quantification of each variant. Several years ago, Lee and colleagues published in the JAMA a meta-analysis indicating that the detection of minority-resistant variants was correlated with virological failure, as illustrated here on this Kaplan-Meier curve, with the red line indicating the patient who had minority variant at baseline, and in the blue line, patient who had no detection of minority variant. And in this study, in this meta-analysis, the key mutations that were detected were NNRTR and NRTI mutation. In the context of first-line regimen containing non-nucleoside reverse transcriptase inhibitors, NGS screening of mutation will prevent one biological failure for 11 patients tested. And this was demonstrated in the Lee meta-analysis. In another European multicentric study, the detection of at least one mutant variant was associated to a risk of failure. And lastly, in a recent French multicentric study, a resistant variant to rilpivirine representing more than 5% were associated with biological failure, but only in univariate analysis. In the context of previously treated patients with nevirapine, it was demonstrated that key NNRTI mutation was associated to a risk of failure multiplied by 3. But several studies also indicated that minority variants resistant to PI or integrase inhibitor had no impact on the virological response. The Vela system consists of several instruments allowing a high level of automation for routine laboratory. As you can see here, there are instruments for extraction, library preparation, PCR, and sequencing, and of course computers. The different steps of the workflow are shown here. It takes approximately 3 days to get the results. The first day is dedicated to extraction, PCR setup, and PCR amplification. The second day is dedicated for library preparation and emulsion PCR. And the third day is for enrichment and sequencing and reporting the results. The setting up in the laboratory was made in accordance with laboratory rules for preventing PCR contamination. And we decided to have an instrument for extraction in the extraction room to the right, and the other instrument in the post-PCR and post-PCR for sequencing. 2 genomic regions are used for genotyping, one for protease and reverse transcriptase, and the other for the integrase. The objective of this study was to evaluate the diagnostic performance of the Vela system, to perform a prospective evaluation versus Sanger sequencing, and to determine the impact on the laboratory workflow. Regarding the analytical sensitivity, we use sample of subtype B and AG and these samples were tested for detection of drug-resistant variants. And we use a 1% threshold for reporting low frequency, low drug-resistant variants. The results can be summarized by a sensitivity for detecting drug-resistant variants at 500 copy per ml, and the sensitivity for detecting minority drug-resistant variant was 5% at 100,000 copy per ml. Regarding mutation analysis, this table shows the mutations that were detected by Sanger and the mutation detected by the Vela system. In this experiment, the mean viral load was 6.5 log copy per ml, and different subtypes were included. And there was an overall agreement, excellent, 97%, between Sanger and Vela. Another study recently published compared Vela to Sanger sequencing. And in this analysis, 138 protease and reverse transcriptase and 39 integrase sequences with high rate of mutation were used. And the investigator used a 5% threshold for reporting low frequency drug-resistant variants. And there was an excellent concordance of 99.9% between Sanger and Vela. And globally, there was a higher level of resistance, as expected, with Vela for 18% of the protease and ERT sequences, and for 5% for integrase sequence. In our prospective evaluation, we use 198 plasma samples. 73 patients were treatment-naive patients, and 124 patients were pre-treated. Regarding the comparison between Vela and Sanger for protease and reverse transcriptase mutations, the results are summarized here for treatment-naive patients. In these patients, the viral load was 5 log copy per ml, and the success rate was with the NGS was 99%. There was only one failure, and there was a failure also with Sanger sequencing, and the patient had a low viral load. The prevalence of resistance to PI was 21% using NGS, and there was an overall agreement with Sanger of 94%. And there were 4 discordances with drug-resistant variant detected only with Vela, and the frequency of this mutation were below 20%. The prevalence of resistance to an NRTI and NRTI mutation was 14% using NGS, and the overall agreement with Sanger was 97%, with only 2 discordants with drug-resistant variant detected only with Vela. Regarding pre-treated patients, the viral load was 3 log copy per ml, so the viral load was lower. And the success rate of NGS was 67%. There were 36 NGS failure, but 20 set samples have experienced a failure using Sanger too. And the mean viral load in this failure was 2.1 log copy per ml. The prevalence of resistance to PI was 31%, and there was an agreement with Sanger of 86%. The prevalence of resistance to NNRTI was for NRTI 33% and for NNRTI 24%. And the overall agreement with Sanger was 94%. Regarding Integrase genotyping, in treatment-naive patients, the results are shown here. The success rate for Integrase genotyping with NGS was 99%. There was only one failure, and the viral load was low, 2.4 log. And we detected 4 patients with resistance to integrase inhibitors, giving a prevalence of 5.6%. And the characteristics of the patient are shown here on the table. The results were used by the clinician, and all these patients had a therapeutic success. Regarding integrase genotyping in treated patients, in these patients the viral load was lower, 3 log copy per ml. There was NGS failure, and for this patient the mean viral load was 2.2 log copy per ml. The success of integrase genotyping with NGS was 72.5%. 6 patients with resistance to integrase inhibitor were detected, giving a prevalence of resistance of 7.6%. And the characteristics of the patient are shown on the table. We had also an experience of genotyping using DNA based on PBMC samples. We use 20 buffy coats with HIV DNA concentration measured using the biocentric test. The protocol used allowed the loading the nucleic acids extracted on the centosa with the application allowing to test plasma and extract in the same run. As you can see, there was an influence of HIV DNA concentration on genotyping success rate. And in fact, we compared also the success rate between Sanger and Vela, and the success rate with Vela was higher compared to Sanger for protease, RT, and integrase genotyping. And of course, as expected, the number of mutations detected was higher with Vela compared to Sanger, but the clinical relevance need to be evaluated more deeply. Regarding the impact on the laboratory workflow, to finish, the end-on time for 15 samples are shown here. 45 minutes for extraction, 35 minutes for library preparation, 20 minutes for template preparation, 2 hours for sequencing, and 30 minutes for data analysis. In total, 4 hours for end-on time. And when we compared with Sanger sequencing, there was a reduced end-on time of 3 hours because the end-on time for Sanger sequencing was estimated to 7 hours. However, the TAT was 2 days with Sanger versus 3 days with Vela. In conclusion, we observed the good analytical and diagnostic performance of the Vela system. This system is suitable for resistant genotyping on HIV DNA for individuals with low viremia, but more data are needed to evaluate the clinical relevance on this topic. Vela provides an automated platform with throughput adequate for resistant testing in routine clinical practice. Further improvements are awaited, reduction of remaining manual steps, and a need for a quick update of the list of mutations for interpretation for all interpretation algorithms. And to finish, I want to thank all my collaborators in the lab, particularly Stéphanie Raymond, and the clinician Pierre Delobel, and also Vela people. Thank you.